Great to see everyone, although we can't really see. I am Carl Bouthillette. I'm a senior investment officer at the California Healthcare Foundation in the Innovation Fund, California Healthcare Foundation, or CHCF. And welcome to our session on innovation in the safety net. Now, before we get started and I introduce the speakers, I wanted to give you a quick background in history about the California Healthcare Foundation. We are a private foundation dedicated to ensuring that all Californians receive the care they need in the right setting, at the right time, and at a price they can afford. We are focused on the delivery system for low-income Californians, and given that focus, it only makes sense that our top priority is really strengthening the state's Medicaid program, which is called Medi-Cal. In California, Medi-Cal actually serves 1 in 3 Californians, so almost 14 million people. And we use our $800 million in assets to pay for convenings, grants, in addition to making investments. And at this point, you've probably noticed that my last name is a bit unusual. I speak with an accent. And that's because I was actually born in Quebec in Canada. And my parents moved to Texas when I was 12. So I speak French with a Texas twang. And so it's a bit unique and different accent, and that's a little bit what we're unique amongst our peers at the California Healthcare Foundation. And that's because we actually make investments in for-profit companies. So that's unusual for a foundation. And we do that in venture-style investment types. We do low-interest loans with some warrants, but we can also do equity. And we really look for companies that have solutions that have already been proven, say, in a commercial setting, and we help them navigate the Medi-Cal system, so the Medicaid system, and really help them de-risk the entry into the Medi-Cal market. We offer flexible capital, but also really the strategic insights and the relationships with providers and payers in California. But today we're going to talk about innovation in Medicaid overall, which is 20% of the population in the US, so families and individuals, 70 million people in the US. And today we have 2 great speakers to talk about this topic, Rich Roth and Leah Sparks. And I'm going to ask each of them to introduce themselves, talk a little bit about their responsibilities, as well as the population they serve.
Great. Thanks, Carl. Great to be here. Thanks to Rock Health and the organizers for hosting this panel today. This is a really key, critical topic, I think, for everyone. It's being, I think, increasingly realized as something that needs to drive the healthcare system going forward. So, Rich Roth, I lead innovation for Dignity Health. Dignity Health is a community of 60,000 individuals, doctors, nurses, technologists, respiratory care providers, and others, all committed to improving the health of the communities. We have many different touch points. What we do that from hospitals to physician's office, in people's homes, and others. And we're very focused on the poor and the underserved. We service probably 70% of our total patients are in the Medicare and Medicaid program. We're the largest provider of Medicaid services to the residents of California. I lead our innovation practice and program, and that really focuses on 3 areas: IP and tech transfer, the things that our employees and physicians create, and bringing those to life at scale. Our early stage program, where we work with 3 to 5 young emerging companies at any given time, focused on scaling those. And then similar to Carl, we also have an investment program and really focus on themes that are focused on value-based care and really hoping to transform care better for the future.
Cool. And I'm Leah Sparks. I'm CEO and founder at Wildflower Health. Wildflower produces a mobile-based software that helps women and families better connect to healthcare at various times in a family's life, from pregnancy into pediatrics and beyond. Our customer base are health plans and providers, as well as employers. But in the health plan space, we have contracts that cover about 50 million covered lives. About half of those are Medicaid, and we'll talk more about that. And then in the health system space, we work with about 100 hospitals, including the hospitals at Dignity Health. And so in that market as well, we're serving a lot of Medicaid patients. So happy to say more about that.
Great. So there's 3 general areas we're going to cover. One is why Medicaid is an important market and a growing market. Second, what do customers look for when you think about delivering services to Medicaid patients? And as well as what does it take to be successful? And just a quick reminder, you can actually send questions, which I'll get to see and hopefully incorporate in the discussion by going through Slido sign up through the RHS Summit team. So, Rich, let's start with you. So, Dignity serves all different types of patients. What does innovation have to do with serving your most vulnerable population, and how do you see innovation targeted at these patients?
Yeah, it's funny, here we are in San Francisco, Silicon Valley, Rock Health, bastion of digital health. But actually I would say, the most important innovation for communities at large are services, right? Services that touch people every day, that help them with the challenges and issues that they have. And I think services that, get at, some of the heart of the fragmentation of our delivery system. So I think my favorite thing that we've worked on over the last couple of years is actually an innovation that comes out of Washington, D.C., which is the CMS Innovation Center.
That's an oxymoron.
Yeah, I know. So, surprise, surprise. I had a chance to be an advisor with the last administration. And, one of the things they did was a bundle payment program, which I think is a symbol of the types of collaboration that can really yield benefit for all types of diverse communities. And basically what that is rather than hospitals being paid episodically for when a patient comes in, they're allowed to take care of a patient several days before they come in as well as 90 days after, which forces them and incents them really to collaborate with skilled nursing providers, to focus on prevention, to work with novel technologies that keep people out of the hospital. We've serviced about 40,000 patients under this program. We've saved almost $1,500 per case through CMS by this better coordination, by getting people home care services, which we've increased by about 20%, in this target population. It's really just a symbol of what I think is so important for the Medicaid population, which is taking care of people under risk, right? And so getting the payers, getting the providers, getting the emerging companies to work together under a risk structure that benefits the health and the preservation of these populations.
That's great. Leah, so how does your business serve low-income populations, and how do you do so effectively? Particularly, have you had to adapt your solution to serve those patients?
Yeah, so I think for our business, if you're going to work in maternal child health and scale a company in that space, you have to work with populations at all income levels. If you just look at the numbers, and you alluded to this, Carl, 45% of pregnancies in the United States are financed by Medicaid. In some states, it's as high as over 60%. And then if you look at children in the United States, there's 45 million kids on Medicaid, which is just over 60% of kids in the United States. So if you're going to be in maternal child health, and if you have a passion, like many of us do who work in digital health, to actually impact the hardest outcomes and the biggest healthcare problems there are, you need to work in this population. So from the beginning, we knew we wanted to serve the population. What we did not know is that literally our very first customer 6 years ago was the state of Wyoming Medicaid. Our second customer was a Silicon Valley large employer. So from the very beginning of this company's history, we've had to really span both of those demographics and figure out a technology solution that helps both of those demographics connect to the innovative services using technology that they need when they need it. And so in terms of how we've served the Medicaid population and had to adapt, there's a couple of things we had to build into our technology to really serve the population well. First of all, it is a myth to say that Medicaid moms don't use technology, because they do use technology. They do have smartphones, something like 85% now have smartphones. And more importantly, they're very dependent on the smartphone. They may not have a laptop. So to serve this market well, you need to be focused on the mobile device. What they may not have is a rich data plan. So we had to build our apps so that they run offline. So unlike Facebook that you can't use on the plane, you can open our app in airplane mode and still get the content information about Medicaid benefits and whatnot. You can't obviously make a call or click to link without a data plan, but you can still get the content, and then we can pull in your data when you get back online. We obviously also had to optimize our applications for low-end phones so that we serve all types of phone types. And then finally, something people don't often know about Medicaid when you get into it is that every state has a different literacy level. So our content is actually configurable at the literacy level. And so we have some versions of our app in 4th grade, some in 6th grade. And the states generally want to approve all the content. So you have to kind of go into it with that lens. So those are some examples of how we've had to adapt this population.
So one other question came through actually is how you're addressing low health literacy and engagement in vulnerable populations. you mentioned a couple of adjustments there. Are there things in languages, are there things that you've had to take into account?
Yeah, we are also a multi-language platform and obviously are in Spanish as well as English and have a platform where we can go into other languages depending on the needs of our clients. But yeah, I mean, one of the things that we discovered early on, again with this dynamic of having a first client in Medicaid and a first client in Silicon Valley, we built our first version of our content at the 6th grade level, and we found that a lower literacy level works better for everyone. Especially when you're consuming content quickly on a mobile device, you don't want a lot of jargon and terms that don't make sense. So simple, clean, easy language is actually better for everybody.
Yeah, great. So Rich, you talked a little bit about, or you mentioned fee-for-service versus value-based care. Most of Medicaid is managed care. So how is that helping you thinking about transitioning to more and more value-based care as you think about the overall services that you're offering at Dignity?
Yeah, I mean, everything we do really is working towards this concept and idea that we need to take risk for populations. And risk for populations allows us to do so many different things. Because when you think about, when I think about something like convenience, right? And you think about, I appreciate convenience. I mean, I like the idea of going onto an app and being able to get that information and to schedule and to book and to look at my records or, whatever it may be. I don't know if anyone likes looking at records, but if I put myself in the place of someone on Medicaid, they need that convenience more than I ever would. I'm a wonder they need. It could mean they're going to miss a shift at work if they have to be in the emergency room. Could mean they can't get their child to school. And so, we're really about a couple things. One is, building a robust set of digital services to be able to serve patients wherever they are, however they like to digest the information, working with our own internal build as well as great partners like Wildflower. And then really heavily investing in high access points, primary care, care in the home, on-demand care, ways that we can get services as rapidly and as frequently in the most preventative nature as possible to those populations. So we think, if we can invest in those areas, we have great hospitals, we have amazing surgeons, we have great nursing teams. When people need them, they'll be there, but we need to get more grassroots in the community to succeed under risk.
There's a question moving up quickly here is, how are you building trust in low-income communities? So that's, I'm sure there's maybe not as much trust. Do you think about that? Maybe from your perspective, maybe from an app, how do you trust them?
I mean, number one, we've had hospitals and communities for 100+ years. I mean, if you actually look at study for trust, what do people trust? They trust physicians, they trust nurses, they trust hospitals. And so we actually have a very sacred position there. And that's actually why when we work with emerging companies, we actually have a lot of criterion and things that they work through because in some way they're a semblance of our brand. So, we've been deep in communities for long periods of time and we work with community organizations and fund community organizations as part of who we are. So whether that's FQHCs, whether that's Meals on Wheels, whether that's housing programs, we really want to extend the trust that we have and get closer and closer to patients and families that we can benefit, their health.
Yeah, and I do think it's a good question. So one of the things that we've confronted, a little anecdote, is we use our technology to try to screen for issues and risks and connect women and families to programs and services that'll help them. And it's a whole range of things, right? It could be domestic violence, it could be things that are, substance abuse problems. And one of the things we found early on with some of our Medicaid populations is that women, we typically like to authenticate you with your Medicaid ID so we can pair you with your plan and connect you with your, medical record ID. Women were hesitant to put in identifying information like Medicaid ID because they were afraid they would put in they were having a substance abuse problem and Child Protective Services would knock on their door. So we had to create some flexibility for many of our applications where you can enter it anonymous, and we don't always know who you are, but we're still trying to connect you to the services. So you have the option to put in your Medicaid ID or not as a way to sort of bring down that barrier of fear is one thing. But the other thing I would say that we found is that our Medicaid users are actually slightly more engaged in our applications than our commercial users. And I pulled a stat because my team did this study that we've seen in our data that our Medicaid users launch our application 30% more often than our commercial users and have a 5% higher retention rate than our commercial users. And what we really think is behind that is just, you were saying, everybody wants convenient access to healthcare, but when you are in a vulnerable situation, you really need convenient access to healthcare, and you need all of those programs and services, whether and it's not just plans and providers, it's the WIC Center, the Head Start Center, the public health nurse, or the transportation service, and trying to make that really easy for you to find is just so powerful, I think, in this population.
Speaking of data, there's a question that came out in terms of what you've seen, Leah. What outcomes in Medicaid populations have you seen? Do you have any published data?
We do. We published a peer-reviewed journal article, and Dilek Barlow from my team is here, who was one of the study authors. There she is. We were able to do a peer-reviewed journal article in the state of Wyoming, showing that the app users had higher rates of the HEDIS measure for prenatal appointments, 75% lower rates of low birth weight babies, and lower rates of NICU admissions versus non-app users. And Dilek can answer questions about that study. But we've also had claims analysis. We have a health plan client in a state in the South that did a claims analysis showing that app users had births that were $38,000 less costly than non-app users. And let me be clear, the leading indicator here is not that like an app makes you have a healthier baby. It is that the app users, like in Wyoming, they had a 3 times higher rate of connecting to resources. In this other health plan client, they were 60% more likely to connect with a nurse or provider. So it's making those connections to care and to the services that really makes the difference. It's not, as much as I love technology, it's not the technology that improves the outcomes. It's connecting those women with the resources and clinical programs that they need.
Technology-enabled services.
Exactly,
right.
Exactly.
Rich, from your perspective as a customer of a company like Wildflower, what's important for entrepreneurs to think about when they want to sell to a healthcare provider?
Yeah, I think.
What are your criteria?
We have a pretty firm set of criterion that we work with. We really work with 3 to 5 early stage companies at any given time, and it's based upon themes that we feel important, but it's also based upon the characteristics, many of which Leah embodies. So I'd say the characteristics are as follows. One, we like people that we like teams that reflect the community they're served. In terms of their leadership team and their board. They're diverse, they understand that people have these challenges and these problems and they can relate to them. So when we look at who is going to be a cultural organization of fit with us, that's screen 1. 2 is leaders bring data to the field, right? So what Leah just talked about in terms of actually doing a study, going through that rigor and work, we actually did a fantastic study which is well published together with CHCF with a company called Propeller that focus on connected asthma inhaler. But that's another example of we want people that are going to march with us, they're going to bring data to the field, they're going to do studies because that proves to us that there's value in the technologies that they've developed and we can apply them to these risk mechanisms or other types of ways we're going to try to put together things that can service the community. Third, it's a spirit of partnership, right? So, Leah and other technology companies, they have great business model ideas, they have great technology, they have new and different ways of looking at the world. We have real doctors, real nurses, real clinical care situations, real patients every day, equally valuable in different ways, complementary. And so, an alternative view might, hey, we've worked with this amazing technology company and we're here to solve healthcare. And, physician, if you would just look at this EMR that we've created instead of your EMR, great, it's all solved. Well, that'll never happen, right? They're never going to swivel chairing around. So you've got to understand that these are very busy professionals, deeply caring for their community, and things need to work in their workflow. And so, ultimately, putting those 3 lessons together really to us has been the differentiator of companies that work well with us and companies we invest in and succeed and scale and port and companies that I think have challenges.
Yeah, and if I can just add, I think from a venture-backed company perspective, working with a partner like Dignity Health, just giving a real example, I think to your point, we've been working with Dignity Health for a couple of years, yeah. I think, and delivering a maternity application. And now that we have scale across the system, we've been working with Rich and his colleagues on how do we really tune this for vulnerable populations. And we work a lot with Medicaid on the payer side, but haven't done as much yet with providers. And the Dignity Health team is willing to open up access to their providers or community health centers, like people who can actually really provide very discrete feedback into how we should enhance the product to reach that population inside a health system. And that's just that's good for everyone. Yeah. It's good for Dignity, it's good for Wildflower, it's good for the patients, right? It's just great.
Yeah, we need each other. We need what Leah and her team brings. I think Leah needs what and organizations that recognize that, I think will do well, whether it's with Dignity or any other organization. I think it's just an increasingly realized fact.
So as an entrepreneur, we talked a little bit about workflow, and you brought that up. In terms of, if they have a very good niche solution, do they need to figure out the entire workflow thing? or that's something you would partner with someone to try to figure out what's the right time to approach somebody like
Yeah, we bring them into our, we have shadow programs that we do so that we bring companies in that shadow, working with our clinicians, that shadow our IT teams. We like to see it as a partnership. Whether it's a vendor that we work with, whether it's someone we're invested in, but the end state is really, if it's someone that we culturally believe can help and their product can help service the communities that we serve and help us achieve our mission better, we're going to open up, because we want us both to be better. And by the way, we want them to develop something they can sell to others because that allows them to be stronger and thus we're served better as well. So it's somewhat of a virtuous circle, but I don't think you can get that without working hand in hand with physicians, nurses, medical assistants, administrators, and others. You can't really do it from afar. So you need to get in there and realize that, you may have started the company with this metric and goal in mind. And when we study the data, it might be something else that really resonates with our teams. And so you need to be able to be flexible and incorporate that in your roadmap.
That's great. So Leah, I think you mentioned when we were talking, you had a recent press release announcing that you're taking care of the first 1,000 days of life, and you've partnered with a nonprofit Medicaid plan. Can you tell us a little bit more about how your initial solutions has evolved to something that covers a lot more part of somebody's life?
Sure. So we started 6 years ago with a real focus on pregnancy, which is, I recommend a lot of focus when you first start a company, if anyone's out there first starting something. But as we started looking into some of our early data within a couple of years, we saw that 70% of the pregnant women were still using our app after their due date. And we only had a couple months of content on early newborn visits and things of that nature. So that told us that there was an opportunity here, obviously, to keep extending. And then we also began to really appreciate this idea that the overwhelming feeling you have when you have to navigate healthcare during pregnancy doesn't go away. It actually gets worse when you have kids in the mix, and then you might have aging parents as well to deal with. And it's often women as this sort of chief health officer at the home doing all this navigating. So we've now extended our platform across all of family health, if you will, with a lot of content in pediatrics, some for adult health, aging parents as well, with the idea of serving the sandwich generation really well. But with Inland Empire, we've extended into pediatrics, and their focus is really the first 1,000 days of life. And in the Medicaid population, they really understand that if you look at metrics in early childhood, highest rates of non-emergency ER visits are in the first year of life. We have challenges with getting developmental delay screening that really impacts our Medicaid clients. Something like only 40% of kids are getting child visits that they need. So there's a lot of opportunity for quality and screening improvements in pediatrics that directly impacts the Medicaid program. And so we're really just delighted to have them as a partner to help roll that out.
Well, that's great. Rich, we talked about a little bit the concept of a one-stop shop. How do you actually provide that service for vulnerable populations, but yet still have enough personal care that address their specific needs?
Yeah. So I'm a big fan of ice cream. And it's summer in San Francisco, so it's kind of ice cream time. And I think healthcare likes ice cream too. And but healthcare likes a lot of vanilla, right? So it's here's what our hospital is, same for all. Here's our medical group, whether it be Dignity Medical Group or Sutter Medical Group. It's kind of the same, right? And so we've created a lot of vanilla for people, to digest it. But realistically, we're in an age of personalization and choice, and people like different things like chocolate and butterbrickle and strawberry and secret breakfast and all the other different types of things that are out there. And so, what we need to do at the front door is partner with organizations that are uniquely good at serving different types of demographics and do it really well. So, in the Medicare space, you've got organizations like Oak Street and ChenMed and others, and really what they are, they're community centers, right? They understand the social isolate. I'll never get that word, but isolation that exists between older adults. and they have like community centers that allow for connection and games and other types of things. If it's hot, you can come in and it'll be, cool inside with air conditioning. And while you're doing that, there's healthcare services provided, right? But it's a community center first. There's organizations like City Block that, focus on Medicaid patients and uniquely, and they know to go where those patients are as opposed to waiting for them to come in. Maven, is a great organization of something that came and started really focusing on women. So I think our job as a healthcare system is really to be the 31 flavors, right? So how do we make sure that, when you come to Dignity Health, we have partnerships, we have access points that reflect the diversity of communities that we are, in addition to the people that still like vanilla, because we'll always be there for them. But if we can't work with these other organizations well, I think we'll misserve the community.
Yeah, agree. I like ice cream. My favorite is bubblegum ice cream. They only carry it in the summer at 31 flavors. Along that personalization, how does Dignity think about innovation for behavioral health and combining that service?
Yeah, this is such an incredible need, and it's an area where I think Silicon Valley has failed us, because there's so many, all the things I talked about, what I really love about, the way that Leah conducts her company, there's so many behavioral health companies emerging, but the sad reality is they service only people with insurance, and typically only people with insurance that can pay on top of their insurance, and then they can make great access. Well, I'm not sure they're solving a problem. I'm not to say someone that works for a company and has money is not having depression or other types of challenges. They absolutely are. They're helping to solve a problem, but it's not the problem, right? The problem is all of the people that are on Medicare and Medicaid or uninsured and others, and coming to emergency rooms because that's the only place they can be. Extremely expensive. We're not positioned to serve them with the right types of health that they need, behavioral health that they need. We might be able to connect people through a telesite, but ultimately they should be, cared for with a mental health practitioner in the way that, most people are. And no one's trying to solve that problem. And that's, I think, a great challenge. And those are the types of companies that we're actually actively looking for, is how do we solve behavioral health challenges in underserved populations.
Yeah, I love that you're making that point too, because I said this to someone the other day. It's like when I first started the company and was focused on Medicaid, people were like, "Oh, that's cute. Yeah. You must be a bleeding heart." And the reality is, if you really want to make a difference in healthcare, don't build something that only works for employees at Google and Facebook. Right. If we're really going to change healthcare, we got to think about the vast amounts of people in the population that have big healthcare problems.
Yeah, I think that's a great answer, and I think it answers one of the questions that's at the top here. It says, startups focused on low-income groups generally have altruistic intentions, yet compete aggressively with alternative. How can we encourage collaboration? And I think the reality is, whether you're Dignity or any other provider system, you don't have one type of patients.
Yeah.
You have folks covered by Medicaid, you have folks covered by Medicare, commercial insurance, self-insurance. Yeah. You need to be able to adapt to different types of patients.
It's an automatic screen out for us if you don't serve all patients.
There you go.
If I look at our initial screens of how do we or don't we work with companies, if you're just serving, commercial-only patients, it's, again, it's solving a problem, but it's not solving our biggest problem.
Yeah, so you can be altruistic and successful at the same time. Let's talk a little bit about what it takes to be successful. Leah, can you discuss why it's important to care for families and how it impacts health and well-being across their entire spectrum?
Yeah, and I think kind of building on the conversation, I think as much as we're talking about the importance to meet the needs of vulnerable populations, it's also, it's really just sort of adapting your business model, because like, for example, this idea of family health that we're really focused on, it resonates across all demographics. We really see sort of family as that ultimate population health model. If you really think about, again, the chief health officer of the home, whether it's usually often a woman, but not always, but whoever that person is, think about the number of healthcare things they deal with, over the course of a month versus just dealing for themselves. It's a kind of this natural networked way to impact a lot of health under one roof, truly. And so we really think about that family as a very important hub of decision making that can then be that hub to get you to the right place at the right time across a whole family. And just to bring home the point, I had to pull a quote, because we've been interviewing some of our Medicaid users. He's making fun of me for my paper earlier. I had to, otherwise I don't remember. But to the point of like the idea of this resonating.
Glasses on first.
Yeah, not yet. Resonating across demographics. This is a quote that this is a Medicaid woman on one of our in one of our applications. She's a single mother of 2 teenage sons. And this is her quote when our team asked her about why she likes our application. She's like, Medicaid members need to find lots of resources. I hate having to go to 50 million places to put everything together for healthcare. Does that sound familiar? Like, we all deal with that. This is a great app to use for medical information and find information about Medicaid. You have everything you need in one spot. It makes my life so much easier. But my point here is that this is a common problem. Yes, we've tuned our business model and tuned our technology to work for Medicaid, but it's also important for everyone. So like behavioral health, it's important for everyone. You just got to tune your business model to make it work for all populations.
Yeah. So maybe a question for both of you. Start with Leah. So serving underserved communities often requires a cultural competency. So how do you actually tackle that, both from your perspective as a vendor and maybe as an organization?
It's a really good question. I don't know that we've totally nailed it. We definitely try to have an array of advisors and clinical advisors that represent all populations. So for example, we have a nurse midwife who works in the Medi-Cal population as one of our clinical advisors. We actually lean on our clients and partners who serve the population to better understand it and spend time there. Like when we started working in Wyoming, I mean, I've been to Wyoming myself a few times. I know others in the company have been a lot. I mean, you have to just sort of go and like, because it's hard to have for something to really understand it unless you've been there. So I think it's kind of a lot of sort of boots on the ground and just talking to people to understand the cultural differences.
What about you, Rich?
Yeah, I think that's right. I mean, I think it you need to have employees that are of the community. You need to have leadership that is of the community. You need to, really embrace that as as part of the culture that of who you are as an organization and who you partner with. And we're here to serve communities as Dignity Health, and you can't do that unless you're somewhat of the community. And so I think that's really critical, just as a cultural standard or foundation for who an organization is.
So one of the topics we often hear a lot about is social determinants of health, whether you have access to transportation, housing, food, all those things. Rich, when you think about that, where do you see the opportunities for innovation in that space or better service?
Yeah, I have a great example. So, we're on the UCSF campus, and there's amazing researchers and scientists, and they're doing fantastic work. And so I think of cancer, right? And there's a lot of talk about genomics and cancer and how, understanding who you are on kind of a, molecular level can alter treatments or get you in different trials. And that's fantastic, and we need that research to occur. And, if you happen to live near a place like UCSF, and if you happen to have a health plan that allows you to access UCSF, and if you can get into the physician that happens to know about your clinical trial, and if they're there and can talk to you about it today, then you're going to get fantastic care, right? But the reality is, probably 20% of the cancer care in the country is done by academic medical centers. 80% is done in the community, right? So then you have to shift and understand, if you don't have that plan, and if you live in Omaha, or you live in Tacoma, or you live in Las Vegas or Phoenix or other places, how do you get access to that care? And so what we've been working on is figuring out how you take that information that's really resonant only in academic areas and democratizing that so that care providers in FQHCs, in community clinics, in our hospitals and other places actually have access to the same levels of information that you would typically only get within the higher echelons of academia, and that's actually been a big focus on us. And so whether that's precision medicine related activities, whether that's many of the other barriers that people face in terms of transportation or insurance status or language barriers or other types of things, it's really how do we use a concept of subsidiarity and get it as close to the decision makers as possible so that we can not have information only rest in ivory towers, that everyone that people will access has that information.
And so where do you store that information? How do you get the input to actually capture those social determinants of health so you can disseminate it?
Yeah, it's a real, so when you look at the social determinant of health, I mean, it's a really interesting, issue, and it's almost like a community solution that needs to occur. But, so within our, EMRs or other places that we work with, community providers, and, we're capturing certain elements of social determinants of health. But I think the challenge is individuals are seeing many different providers, or not seeing providers, or seeing alternative providers, and everyone has different types of systems. This is one of the flaws of the healthcare system where, I'll be like, oh, I like, green bottle social determinant system, and you like white bottle social determinant system, and we're two different organizations and we're buying disparate things, and we're crushing the Meals on Wheels and the housing providers and the others. So I think one of the great challenges is how do we come together and have a community-based record for social determinants of health that we all kind of invest into and support, so that everyone gets uniform access rather than really kind of pushing a singular philosophy on the community providers.
Good. So one of the things that's important is partnership. You've brought this up a couple times. Can you share how the Dignity Wildflower Health partnership developed over time? And how has it worked from both of your perspectives? Leah.
It's obviously worked wonderfully. No, I think, it was, so it was really interesting for us because we'd been working in health plans, and Dignity Health was really the first big health system that we worked with. And you all had this bright idea. It's like, look, we need to do more for women and do more in maternity and tech enable some of our major health journeys. And so it was really kind of a first thing for both of us. And I think some of the things that went well from our perspective, and I'd love to hear from you, Rich, is that, Dignity set out with a path to scale. Like, there were very clear milestones. It wasn't like, oh, we're going to just try this and put in a one-year contract. Like, we're going to put in a real relationship and have a path to get you in all of our facilities. And we've now gotten there. And so that, I think, was important because you can't, like, if you're going to do innovation, you can't do it with like just 10 patients in one clinic. You've really got to test it and then give it legs and then let it grow and scale. I think, too, we have just really aligned incentives and aligned cultures, you can probably guess. And the fact that now Dignity is poised to be the first health system we're working on Medicaid with. It's just an example of how I think our alignment and strategies really overlap, which makes the partnership good. And obviously everything comes down to people and having the right resources and people working on stuff. Yeah.
All this stuff is hard. Like even, I think we have great relationships. I think we have very aligned organizations, but, change is hard, and it's really, are you working with someone that can deal with the ebbs and flows, the late night texts, the multiple calls to try to get resolutions and pass through thing that ultimately we have the same end goal in mind, and that's why for us we work with very few in a very focused way because we do want them to port, we do want them to scale, we want them to serve every single one of their communities and be successful outside of Dignity Health as well because we believe what they're doing is the right thing to be doing. And so, I think we were fortunate to find one another. We identify themes, every year that we're looking for. That was one of the key themes in that particular year. We're really fortunate to be, to meet up with Leah and her team through a variety of different methods. But and then, as I think Leah said, our intent is when we bring things is to scale them, and we want them to be scale ready. And that's a healthy tension to get there. But ultimately, we found some great success.
Oh, beautiful relationship. That's wonderful. It's all good.
It's all the white couch.
Yeah, exactly.
Rich, you mentioned kind of innovation. It sounds like it was a priority for you at some point, and then you were looking for a solution, and obviously found Wildflower. One of the questions that came through is, as you think about vulnerable populations, vulnerable patients that you serve, what are some of the innovations you'd like to see?
Yeah. We're really looking at ways to take care of people in the home in a much more robust way, and as close to their local close-knit community. So I think over time we're going to see some hospital at home opportunities that we're going to be doing. I think over time we're going to see some novel partnerships with primary care organizations that really know and understand these communities, and we figure out ways to knit them into our broader network of specialists and hospitals. And I think we still are looking for the right behavioral health solution that really kind of understands these communities and can service them in a unique way that we're not thinking of. And I think the final thing, which is inherent to hospitals in general, whether you're serving vulnerable populations or not, but that as we move to a risk-based world and a population health world where hospitals they'll be a part of the continuum but not the center as they might have been 20 years ago, we still need them, right? I mean, there's going to be car accidents. There's still going to be orthopedic injuries. There's going to be trauma. There's going to be, very complex cancer cases. And so we need the hospitals to be more efficient than ever, so that we can continue to be long and standing viable members of communities. And so we're actually looking at a lot of automation inside the hospital walls and using novel technologies to help us operate better. And I think that helps us lower our costs and then be there for vulnerable communities.
And Leah, as an entrepreneur now that's been successful and developed these partnerships, what are some key takeaways, say 3 key takeaways you would provide entrepreneurs who are looking to build a solution around the Medicaid space and provide partnering companies like or providers like Dignity?
Yeah, I think it's really important to have a clear path to ROI. One of the things I liked about pregnancy when we started was that we could prove an outcome in 10 months. It's true. You don't have to wait. You don't have to wait forever to show a different. So that's what makes things like diabetes really hard. You can still do it. So you've got to figure out your ROI, and quality measures is key, obviously, to getting traction. Doing your research and really understanding this market to make sure you have empathy for it, I think, is obviously really important. And don't be daunted by the biggest problems. I think it's just. There's just so many, again, like in my company, we think about this disparity in maternal outcomes, right, that you see in demographics, and so many of the problems that we have with people who are afraid of going to the hospital because of their immigration status. Right? There's just so many big problems. Don't be afraid of them. We have to get after it as a community in digital health, or, what's the point otherwise, right?
Yeah. Exactly. So we're out of time, so I'll just close with 3 key points. I think one is Medicaid is a really important market that serves vulnerable populations, so we encourage people to take a look at it. There are opportunities. Second, what you just said, I think measuring results and showing an ROI is critical if you're going to be sustainable. And I think the third thing is you can be successful in Medicaid. The key is really you have to find the right partners, and I think today is a really good example. So please help me thank our panelists, Rich and Leah.
Thank you.
Thank you.
And the next session is